Since time immemorial, nature has enabled certain animals to navigate in near or total darkness and find their way. In the absence of reflected light, creatures like the bat rely on reflected sound to maneuver past obstacles and move swiftly to their intended target. This type of guidance system took millions of years to develop. You'll appreciate its accuracy in seconds, because now you can use the same technology to reach your target, a blood vessel inside the human body. Using SmartNeedle, you can hear a vessel through the point of a needle, and you can tell whether it's a vein or an artery. With SmartNeedle, you know exactly where you're going and exactly when you get there. Continuous auditory feedback helps you locate the vessel quickly, puncture it, and optimize the needle position within the vessel. With all of its advanced capabilities, the SmartNeedle monitor is extremely simple to operate. Its only controls are a volume adjustment, which is confirmed by an LED display, and an on-off switch. The SmartNeedle disposable needle assembly incorporates a standard needle, which houses a doppler probe. Let's take a closer look at how SmartNeedle works. Flush the SmartNeedle with sterile saline and make sure that no air bubbles are trapped at the tip of the probe. Holding the SmartNeedle at an angle, insert the tip a short distance into the subcutaneous tissue. Using the tip of the needle as a pivot point, slowly move the needle in a circular motion, listening for the desired flow signal. Arterial flow sounds like this. Venous flow sounds like this. If a flow signal is not detected, advance the needle further and continue moving the needle in a slow circular motion. If an air bubble has formed on the tip of the probe, no flow signal will be heard. It may be necessary to flush a small amount of saline through the needle to dislodge the air bubble. Once the initial flow signal is detected, stop. Continue moving the needle in a slow circular motion until the intensity of the flow signal is maximized. Advance the needle another 1 to 2 millimeters and stop again. Move the needle in a slow circular motion until the intensity of the flow signal is again maximized. Once the needle penetrates the vessel, the signal intensity usually increases. Because the needle lumen is somewhat compromised when the SmartNeedle probe is in place, backflow will not be as brisk as with traditional punctures. Now let's take a quick look at special circumstances that require a specialized approach. Palpation is not recommended when listening for a venous signal. Pressure on the vein may cause the venous signal to disappear completely. If the vessel is calcified, or if the region over the vessel is heavily scarred, the signal may be significantly reduced. If there is a sudden loss of a strong signal, the needle may have compressed the vessel and completely blocked the flow. If this happens, simply pull the needle back slightly until the signal returns. Another possibility when there is a sudden loss of a strong signal is that the needle may have compressed the front and back walls together and then punctured both of them. In this case as well, simply back up slowly until the signal returns. Once you have optimized needle position within the vessel, unscrew the connector and remove the probe assembly from the needle. Now let's join Dr. Paul G. Yock, the inventor and co-developer of the SmartNeedle, as he demonstrates the use of SmartNeedle in a clinical setting.
So what I'm going to do here is I'm going to just check the flush, and I'm going to just put it a little bit into the skin here. And then I'm going to flush again just to clear any bubbles from the transducer. In general, the strongest position in terms of the tip of the needles is between 45 and 60 degrees from flat. And then I'm going to just scan back and forth here. Here's where the signal is a maximum, and it's easy to collapse. Okay, now what's happened here is that I think the phenomenon we described of flattening the vein has just occurred. And so I'm actually going to pull back a little bit. And there we get it again. Okay, now with this good signal well localized, I'm just going to advance on into the vein. Okay, you heard the little poke of the vein. That's the signal from inside the vein. Just going to take the stylet out now. You can shut that off, Olga. And I'll pass the guide wire in. The guide wire will go in very easily because I know I've gone right to the center of the vein using the doppler needle. Okay, now there's a vein signal right there. We've already been in there. We don't want that, so that means I have to redirect a little bit more laterally. There's the artery more laterally as it should be. It's a little surprising actually that it's that lateral, but that's fine. That's where it is. This signal has a much sharper upstroke than the venous signal. It's pretty typical. Now I'm going to optimize that signal. Over there I lose it. There it's beautiful. Over there I lose it. So I want to go in at this trajectory right here. That's optimal. I'm going to advance forward a little bit. Just stabilize here. Okay, now I've gone in the artery. Here to step up. You can see the backflow. Anterior belly, relax. Posterior belly. This is the triangle that will be finding the jugular vein in right there. Okay, now I have a faint venous signal that I'm picking up. It's just barely audible. So I'm going to scan slowly back and forth, try to maximize it, and it's best right here. I'm going to advance a little bit. And I'm getting a slightly stronger signal now. Again, I'm going to stop and optimize it. It's not as good there. Better here. Advance a little bit. Okay, I can hear respiratory variation in this signal. And there are also 2 and 3 components to it. And if I swing away, it's not as good. Over here, it's good. So now I'm going to advance a little more. Now it's still louder. And that's a clear venous signal, a lower pitch, kind of a whooshing quality, and definite respiratory variation. Very close to it now. And that was penetration. I'll confirm that with a little backflow. Okay, now I'm going to take the stylet off. For the subclavian approach, we're going in under the clavicle. It's a little different from the other approaches in that we've got to get in under the bone itself before we can pick up the signal. So I'm going to just put the needle in under the skin. Once again, give a little bit of flush to clear the tip. And I'm putting my finger in the sternal notch as a reference. Just going to give a little puff as I go forward. I'm picking up signals, and it's very pulsatile. So at this point I need to decide whether this is an artery or a vein that I'm listening to. That sounds like a small arterial signal to me, so I'm going to back away from that and advance a little more deeply. I'm running up against bone here, so I'm going to take a different trajectory a little bit. Okay, now we've got another pulsatile signal. This signal is different than the other one in that there's respiratory variation and there's a clear A wave component to it too. It comes in and out with respiration. So I'm going to optimize that signal by moving the needle back and forth. And you can see that with respiration it changes a lot in character. So I'm going to move a little closer in. Here are the changes with respiration. That means that it's a vein. So I'll go ahead and advance at it. I'm going to optimize the position here. And that's entry. The subclavian and internal jugular vein signals are very pulsatile frequently, and you need to be careful to discriminate them from the corresponding arteries. The most reliable indicator that the sound is from a vein is the appearance and disappearance of the ACV signature in the vein signal. These are low velocity pulses that are caused by the corresponding atrial pressure waves. What you'll hear with the big veins is that these contours will appear and disappear with inspiration and expiration. The big arteries, by contrast, have a very sharp, early, high-pitched sound, an explosion at the beginning of systole, and that signal won't change with inspiration and expiration. This is an example of an internal jugular vein signal. This is a carotid artery signal.
As you've seen, SmartNeedle adds the sense of hearing to the search for a vessel. SmartNeedle helps you locate the vessel quickly, puncture it, and optimize the needle position within the vessel. SmartNeedle helps to minimize complications associated with multiple punctures and helps prevent trauma to surrounding vessels and tissue. With SmartNeedle, less time is spent in preparation, so patient care can begin without unnecessary delay. The overall result? Unprecedented confidence and reduced risk. When you consider the advantages, it's easy to see that SmartNeedle is an essential clinical tool. Compared with traditional methods, SmartNeedle is the technological alternative to flying blind